on the behalf of DURG BHILAI Academy of Pediatrics in today's Tuesday PG Clinic session. Today the case will be presented by Dr. Rajkumar. He is second year PG from JLNH RC Hospital and Research Center Bhilai. And as you know, today our faculty and expert is Dr. S Balasubramanian sir. He is very senior consultant, HOD and director from Kanchi Kamakoti Child Trust Hospital, Chennai. I welcome you, sir. Our second faculty is Dr. Ajay Kosam, sir. He is HOD and professor from GMC Medical College, Rajnandgaon. Welcome you, sir. With this, I'd like to invite Dr. Rajkumar for his presentation. Rajkumar, please. Dr. Rajkumar, you can present.
Okay. Let's see the case presentation. Slides. My patient named XYZ, who is a 11-year male child, Hindu by religion, and resident of Rishali, Durg district of Chhattisgarh state, who is a student of 6th class, who belongs to upper middle class socioeconomic status. He was admitted on 8th of November 2024 at 11:30 a.m. and the informant was mother, who was reliable. He came with the chief complaints of fever since 6 days, pain abdomen since 4 days, yellowish discoloration of skin and sclera since 4 days, pain in both upper limbs and left leg since 3 days. Child was doing well until 7 days ago. Later, he fired the crackers as part of Diwali. Later on next day, he developed a fever which is moderate grade and not associated with chills and rigors. Fever was relieved on medication. He was active in interfebrile period. Later on, mother noticed yellowish discoloration of skin and sclera. On the same day, he developed dull aching abdominal pain in both epigastrium and hypochondrium. Pain was generalized and non-radiating and doesn't have any aggravating and relieving factors. The very next day, he also started having severe pain in both upper limbs and left leg just above knee joint. This caused a restriction of the movements around the joint. There was no history of nausea, vomiting, or loose stool. There was no history of anorexia, constipation. There was no any travel history. There was no history of burning, micturition, or hematuria. There was no history of skin rash, joint pain. There was no history of skin bleed or recurrent infection. There was no history of fever with gum bleeds and irritable cry. There was no history of gallstones. There was no history of itching or high-colored urine or clay-colored stools. There was no history of breathlessness or chest pain. There was no history of seizure or loss of consciousness. There was no history of leg ulcers. There was no history of weight loss, night sweats, and night cry. There was no history of loss of appetite. Past history.
Please go ahead.
History of severe pain in upper and lower limbs during episodes of fever since 4 years. There was history of blood transfusion 6 years ago. No history of any significant illness in the past. Birth history. Antenatal and natal and postnatal period were uneventful. It was a full-term institutional normal vaginal delivery with birth weight of 3 kgs. Child cried immediately after birth and had no history suggestive of NICU admission. Breastfeeding was initiated within 1 hour after birth. Immunization history. Child is immunized as per national immunization schedule. BCG scar is present. No additional vaccination was taken and no history of any recent vaccination. Developmental history. Patient had attained all milestones appropriately as per his age in childhood. No history suggestive of any developmental delay. Personal history. Diet history. The patient was on mixed Indian diet. As per 24-hour recalled method, the expected calorie intake was 2,200 kilocalorie per day. The observed was 1910 kilocalorie per day. Deficit was 290 kilocalories. And proteins were expected to be 14 gram per day. The observed was 34 gram per day with a deficit of 6 gram. Appetite was normal, sleep was adequate, and scholastic performance was normal. Family history. The child was second order child born out of non-consanguineous marriage. Mother and father sickle cell. No history of gallstones, splenectomy, or blood transfusion in family members. No history of other chronic illness. Socioeconomic status of the child. Belongs to upper middle class, grade 4 as per modified Kupuswamy scale 2018. Housing was Pakka house with ventilated and kitchen uses gas stove. And the source of drinking water was borewell. Sewage disposal was there and sanitary latrines were used. My patient named XYZ. The summary of the
Don't worry about summary now. Don't worry about summary. Please go to your first slide. Please go to your presenting complaint slide. Very nice presentation, Dr. Rajkumar. Rajkumar, no, your name?
sir. Sir.
Yeah, excellent beginning. Actually, this is a 8-year-old boy.
Sir, 11-year-olds.
11-year-old. Sorry, I'm sorry. 11-year-old who he's an adolescent who has 4 complaints as per your history.
Sir.
One is fever, the other is abdominal pain, third is from what you say, yellowish discoloration, skin and sclera means it is jaundice. It's jaundice, pain abdomen, fever, and some pain in the legs and limbs. There are 4 complaints. Now, in the history, please go to the next slide. Please go to the next slide. Next slide. Yeah. What do you mean by child? No. Please go to the previous slide. The history of present illness. Yeah. In the history of present illness, you have mentioned that child was doing well until 7 days ago. What is the meaning of that sentence of child doing well?
Sir, child was
What
nutritionally
is the
and
meaning? What do you
developmentally
mean by
okay.
that?
Child was nutritionally and developmentally okay, and his school is
Nutritionally and
performing.
developmentally. Okay. In other words, this was an 11-year-old adolescent who was previously well, was going to school, doing well in school, and had no chronic illness. Am I right?
Sir.
Yeah. Okay. That is always better to qualify such statements such as well. You could have described that everything was fine with him. Now you are coming out with a statement that he was absolutely well, going to school, developing normally, etc. Okay. Then the second statement you are making, later he fired crackers as part of Diwali. What is the relevance of that history?
Sure, it can be causative for hypoxia or any allergen stimulant.
What is the relevance? What is the relevance of some 11-year-old child firing crackers with your history and your diagnosis? In what way it is relevant?
Sure, it can cause hypoxia or it can cause any triggering factor for any disease, sir.
How can it? It's okay. In a normal child, can it cause hypoxia to firing crackers?
No, sir. In a normal child, it can't cause.
You have said that he is a normal child. Why did you? I'm curious to know why you have specifically mentioned that he fired crackers. What does that mean to me? I don't understand.
As per mother, the child was doing well. Everything happened only after firing crackers.
You are only giving evidence for his normalcy by saying he fired crackers. Am I right?
Sir.
Okay, right. Otherwise, I don't think crackers have got anything to do with Can you connect crackers and some childhood illnesses? Firing crackers and childhood illnesses. Can you give examples?
Any chronic hypoxia condition can aggravate, sir.
Chronic. Give examples of chronic hypoxia conditions.
Sir, asthma can be there, sir. Asthma.
The most common trigger for asthma is smoke. Smoke of any form, whether it is due to crackers or due to cigarette smoking, it can aggravate hyperreactive airways disease or obstructive airways disease or asthma. That is one. Other than precipitation of asthma, what other illnesses can be triggered or created by too much of crackers? Can you give examples? The most common problem is burns. Isn't it? Burns and scalds.
Yes, sir. Yes, sir. Burns.
Burns and scalds. They are the most common hazards. Okay. Heat burns due to crackers. That is common. And they often can get hurt in sensitive parts of the body like eyes. Right? And rarely children who have got pica, they can ingest the powder that is there in many crackers. Okay. They all contain toxic substances, including sulfur. They can create toxicity, right? And it
sir.
can worsen hypoxia in a child who has got a chronic hypoxic illnesses like cyanotic heart disease or bilateral restrictive lung disease, etc. Okay, that is regarding crack.
Okay.
In addition, very loud noise can damage the hearing. Damage the hearing. Somebody has put triggering of seizures. Yes, children, who have photosensitive epilepsy may see the crackers and the sharp. They may, because of the sound or because of the bright light, they can develop seizures. Okay, that is one. Okay. The second symptom, the first symptom, you're saying fever, and then this yellowish discoloration is jaundice or is it keratonemia?
Sir, it seemed to be jaundice only, sir.
Why? I'm saying this is keratonemia. Agree or disagree?
Sir, no, sir, fever, mostly jaundice only, sir.
No, I'm saying this is keratonemia. Whatever yellowish discoloration you're describing. You should reject it saying that
Sir,
keratonemia never causes yellowish discoloration of sclera.
yellow discoloration of sclera.
It is only skin.
Okay, sir.
Okay. Jaundice is not. So fever for short duration and then jaundice. The third symptom you have mentioned, dull aching abdominal pain in both epigastrium and hypochondrium. So not radiating, okay. And then the fourth symptom, severe pain in both the upper limbs and left leg just above the knee joint, causing restriction. What do you think is the cause for the pain?
Sure. Can be viral fever also can cause pain, sir. It can be arthritis, it can be arthralgia.
It can be arthralgia, but you are saying only pain. But you are not said anything about joint swelling.
No, sir, there was no
arthralgia. Or where was the pain? The pain was in the muscle, or it was a neuritic pain, or an arthralgia, or a bone
muscle
pain.
pain, sir. It was muscle pain, sir. Mostly
And
muscle
that you should specifically which portion? How does muscle pain present? Which portion of the leg usually causes muscle pain?
Calf muscles, calf muscle.
Calf muscle. Okay. And was it unilateral or bilateral?
Sir, upper limb it was bilateral, sir. Lower limb it was unilateral.
Unilateral. Please go to the next slide. Next slide, please. Yeah. See, there is a whole lot of negative symptoms. And, please go to the negative history. Now, I am going to ask you, why did you mention nausea, vomiting, loose stools?
I'm thinking acute hepatitis, sir.
Does hepatitis cause diarrhea?
No, sir. Diarrhea least common, sir. It can cause anorexia, constipation, and nausea.
Okay. Travel. What is the significance of travel?
Sir, any ingestion of outside food or anything, contaminated water.
How does that cause a problem?
Something which is contaminated can cause any infection.
That can happen in India even if you sit at home. Okay. I don't think is very relevant, except that, travel history may be important for diseases like malaria or Kala-Azar. Okay.
Yes.
Right.
Yes.
Burning micturition and hematuria, what for? What's the relevance?
Sir, hematuria for hemolytic uremic syndrome, sir. Burning micturition for UTI.
Hemolytic uremic syndrome. Why did you think of hemolytic uremic syndrome in a child who has got fever and who has got jaundice and who's got some limb pain? In 11-year-old,
Sir, we don't know whether the child is having
unusual. Unless there is renal failure, I don't think you should think of HSP. I mean, you should think of hemolytic uremic syndrome. It's not relevant. What about rash and joint pain?
Sir, related to any connective tissue disorder and arthritis related.
Okay. Skin bleed or recurrent infections?
Sure, autoimmune disorders or any platelet
Do
related.
autoimmune disorders cause recurrent infections?
Sorry, sir, immune related, sir, not autoimmune. Immune related.
No, you have said autoimmune disorder. Do
Sorry, sir,
autoimmune disorders cause recurrent infections?
Pardon, sir. Severe immune deficiency disorders, sir, not autoimmune.
Okay. Skin bleed, why did you ask?
Sir, platelet disorders.
Platelet disorder. Why did you think of platelet disorder in a child who doesn't have any rash? Who has jaundice? I don't think it is relevant. Okay, you should not be quoting all negative histories without justifying why you asked those questions. What about fever with gum bleeds and irritable crying?
Sure, for leukemias and also.
Leukemia. Do you think of leukemia in this child who presents with jaundice? How common is jaundice in a child with leukemia? And how does jaundice occur? What type of jaundice occurs in leukemia?
Sure. Very rare presentation only.
Very rare. I don't think I would have asked that at all. Gallstones history. Okay.
History of
Okay,
thalassemia.
fine. Fair enough. Fair enough. Abdominal pain, jaundice, yes. Itching, high colored urine, clay colored stools. So what?
Sir, to rule out cholestasis.
Cholestasis. Okay. So what type of jaundice this child is having from the history? Do you think this child is having a hemolytic jaundice or hepatocellular jaundice or a cholestatic jaundice?
Sir, this is hemolytic jaundice, sir.
Hemolytic jaundice.
Mostly hemolytic jaundice may be there, sir. Why?
Oh,
Because
how did you come to a conclusion that this is hemolytic jaundice?
Sir,
How did you come to?
in
The
cholestatic,
fact that the urine is not yellow.
not high color.
The very fact that very fact that the urine. Hello.
Sir.
Hello.
Yes, sir. You were audible, sir.
Yeah. Sorry. There's some phone call interrupt. No,
Okay.
the very fact that the urine color was not yellow indicates that it is not a
hemolytic.
conjugated hyperbilirubinemia. It might be an unconjugated hyperbilirubinemia. Okay. Right. Next is itching, right? Breathlessness and chest pain for what?
Sir, it can be in sickle cell acute chest syndrome, sir.
Acute chest syndrome. Okay. Seizure and loss of consciousness.
Acute stroke in sickle cell.
Okay. Leg ulcers for what?
For sickle cell disease only.
Sickle cell. Okay. Weight loss, night sweats and night cry for what?
Malignancy, leukemia, sir.
Malignancy. Loss of appetite for what?
For same malignancies.
Okay, please go to the next slide. Yeah. Past history. Now, past history, what did you get? History of severe pain in the
Pain in upper and lower limbs during episodes of fever since 4 years.
What is the relevance of that?
Sir, mother told that child was having severe limb pain.
No, what mother is saying, but what is your interpretation of this? How many times he has had pain in the limbs during episodes of fever? How many times he has had fever over for last 4 years?
Sir, there was no proper history regarding the number of episodes.
Now, see, that's the biggest problem. See, most of the students, when they are not able to defend their history, they'll always say, that is what the father said, that's what the mother said. See, you must remember, mother and father don't attend to clinics like what you are attending today. They have not been trained. It is up to you to get the proper history. If it is irrelevant, leave it. Okay, I don't know how many episodes of fever are there. Any viral fever can cause limb pain, and a child might get 1 or 2 times fever with limb pains in a year. I don't think it is significant unless there is a definite pattern suggestive of recurrent myositis, etc. Okay. Very importantly, you have said blood transfusion 6 years back. Now, you must give me more details. Why did he receive blood transfusion? What transfusion did he receive? What was the amount that was given? What treatment did he have?
Sir, no, as per mother, no documentation was available, sir, regarding the
Oh,
blood
man,
transfusion.
as per mother, why did they go to a hospital 6 years back? For what?
So they
Even
went,
if they went.
they went to hospital. Why? Because the child, they went to hospital for fever, sir. By seeing the child, they told that the child is having severe anemia. We should transfuse the child. Later on, he was given blood transfusion. No proper diagnosis was made at the
They
time.
went for an acute febrile illness.
Febrile illness, sir.
You must say.
Child
They
was taken
went.
to hospital for acute febrile illness. Later on,
Okay.
which it was found that he was having severe anemia, and child was given transfusions,
Child was given.
blood transfusion, packed
See,
red blood cells.
no, what I want to know, child went to hospital for an acute febrile illness. Am I right?
Sir. Sir.
And what was the indication as per the doctors for the transfusion? What transfusion is given?
Severe anemia was there, sir, as per
Severe anemia. And they gave a blood transfusion.
the transfusions.
Right. You have mentioned that there is no history of any significant illness in the past. You don't think that this illness requiring transfusion was not significant?
Sir, it is significant, sir. What I
Then
meant
why are you mentioning the statement that there is no history of any significant illness in the past?
is regarding another chronic illness, sir, like congenital heart disease.
You are contradicting you think getting a transfusion for a child who's 5 years old is not a significant illness?
No, sir, is significant, sir.
It is a significant. So you should not say no significant illness.
Okay.
Now, at that point, what did the parents know about this illness? See, it is always, at the end of any history, you should always catch hold of a few points. One, what is the treatment that is been advised? Even if they don't take it, doesn't matter. What is the treatment that has been advised in the previous hospital when the child got admitted for this transfusion? Second, you should also find out what the parents have understood so far about the child's illness and their attitude. They are very important parts of history and also medication history. You should always take, and if they have not understood, it also indicates that our system is failing. If the parents have not understood the implications of a diagnosis of a disorder, of a severe anemia requiring transfusion, they have not understood, that means our system is not working. So you must find, not to criticize the system, I'm saying this, but we should get all the data as far as possible from the parent. Okay?
Okay.
Next.
So I have one question.
Yeah, please, sir. Please go ahead, sir.
No.
I thought I just finished the history, hand over to you, sir.
No.
You can ask, sir. Please join.
Yeah. So you just mentioned that the patient had received a transfusion at the age of 6 years. So what do you think was the reason for transfusion? Febrile illness followed by transfusion. Was it malaria or some other illness that might have led to anemia and transfusion?
Sir, it can be malaria, sir. It can be.
It could well have been malaria causing anemia, causing transfusion.
It can be, sir, or it can be thalassemia. It can be sickle cell anemia also.
So when you have asked the history that he had received transfusion at the age of 6 years, you should have taken a detailed history from the mother regarding whether it was malaria, whether it was a sickle crisis, or whether it was something nutritional going on. So how will you differentiate by history that whether it was a nutritional anemia, or it was infection causing anemia, or it was a hemolytic anemia requiring a transfusion? And thereafter, he did not receive any transfusion?
No, sir. That was the only time he
After the age
received
of 6
transfusion,
years?
sir. Thereafter, no, sir.
And
Thereafter, he didn't
before
receive
that
any
also, he did
transfusion.
not receive transfusion.
That was the only.
Okay, so if a patient received,
That
so
was
if a
the
patient
only.
is receiving first transfusion, at the age of 6 years, what are the various hemolytic disease you should consider at the age of 6 years?
At the age of 6 years, it can be thalassemia intermedia, sir. It can be any, it can be thalassemia intermedia, it can be sickle cell anemia, it can be iron deficiency anemia, sir. It can be.
So did you try to find out the cause of transfusion at that age? Did the child have jaundice when he required transfusion?
No, sir, there was no jaundice at the time of transfusion, sir. Transfusion was given only for severe anemia.
So did he had any altered sensorium?
No, sir, no history of any altered sensorium, sir, at the time.
Okay, so you know the history, but you should detail it when you are presenting the history of transfusion.
Okay,
The
sir.
history of medication is taking from the age of 6 years.
No, sir, no history of any medications.
Okay, he's not taking any regular medication from the age of 6 years.
No, sir. No, sir, no, not taking any medications.
Okay, okay, continue. Yeah.
Okay, let me ask a very peculiar question to you. Good questions asked by Dr. Ajay. Let me ask a very peculiar question to you. You have in front of you
Yes.
2 children in your ward.
Okay, sir.
Both are of the same age. Both have a hemoglobin of say 3 grams. One has hemoglobin of 3 grams with iron deficiency anemia. The other child has say thalassemia major, 3 grams. Both are severely ill. You have only 1 unit, same blood group. You have to decide which patient you are going to give. Which patient will you give priority to give a transfusion? And why?
Sir.
I hope you get my question.
Yes, sir. I would transfuse thalassemia major patient, sir.
Why?
Sir, thalassemia major is a very severe disease which
Okay.
can
Can
cause
anybody put in the chat
complications.
box? Can anybody put in the chat box to whom they will give a transfusion? Okay. The correct answer is you should give only to the one who has iron deficiency anemia. Shall I tell you the reason? In general, any child with thalassemia major is likely to have a chronic anemia. The system is likely to get adjusted to the chronicity. The 2-3 PG levels, okay, will be very high in children with chronic anemia. So even in the presence of a hemoglobin of 3, they'll be able to deliver oxygen to the maximum. But somebody with iron deficiency anemia, which is likely to be less chronic than thalassemia, the system is not likely to be adjusted. They are more likely to die due to decompensation. So that is because the 2-3 DPG levels may not be as high in iron deficiency as in sickle, chronic sickle or chronic thalassemia. That's the answer. I hope you get the point.
Sir.
Okay. Right. That's one. Second thing is in the negative history, everything you mentioned. Did you mention anything about abdominal distension? Did you ask?
Sir, there was no prominent abdominal distension, sir. Only there was no distension, sir.
Why should you ask that question?
Sir, for any
I would ask
organomegaly.
for abdominal distension earlier before this illness and also after the illness.
For any organomegaly, sir, or for any
Excellent.
collection.
You didn't mention that. Okay, please mention.
Okay.
Okay, right. Now birth history. Okay, essentially okay. Immunization. Okay. Next slide. Next slide. Development. Okay, fine. Next slide. In development, there is the boy, isn't it? Mixed Indian diet. Okay, diet, there is nothing relevant except that, it's a minimal deficit of calories and proteins. Go ahead. He's not on any vitamin supplements.
No, sir, he is not on any vitamin supplement.
He's not on any micronutrient supplements. Okay, please go to the next. Next slide. Please go to the next slide.
One point I want to clarify in this particular slide. You just mentioned that scholastic performance is good. You have mentioned, no?
Yes, sir. Yes, sir.
Okay, so when you are talking about a patient who has received a previous transfusion, and here you are suspecting a prehepatic jaundice or hemolytic jaundice. So what is the relevance of that scholastic performance, and does it have any significant relevance to this?
Sir, in Wilson's disease, there will be diminished scholastic performance, sir. It can be there.
Or if it is a hemolytic anemia, then?
In hemolytic anemia, there can be CNS symptoms or focal neurological deficits may be there, sir.
There is no history of focal neurological deficit. You mentioned that. Previously, there is no sign. In this, there's no history of focal neurological deficit. And you have clearly mentioned normal scholastic performance that has got a very important statement. This is a very important statement. Can you explain why?
Sir, why? Because there is no involvement of CNS, which has caused a significant abnormality. There is no significant CNS involvement.
Okay, what does that mean? You have to clarify your statement.
There is,
So what is a silent stroke?
sir, silent stroke is a stroke which doesn't show any symptoms, but there can be findings in MRI, sir.
Okay, so in a patient who is a sickle cell patient, suppose, and if he develops silent strokes, so definitely there will be some problem with cognition, intelligence, or scholastic performance. So if you are saying that this child's scholastic performance is normal, then most likely he has not suffered a silent stroke previously.
Okay.
Okay, so scholastic performance is very important, and you can diagnose silent stroke only by MRI. If you don't do an MRI,
Okay, sir.
you will never be able to diagnose a silent stroke. So this is important. Yeah, continue.
Go ahead. Please go ahead. Family history. Family history is something. Please go to the previous slide. Please, just a minute. Just sorry. Yeah, and father and mother are known cases sickle cell trait. What about the elder sibling?
Sir, elder sibling is normal, sir.
Normal. Okay.
Normal.
In this case, you have to put a pedigree chart. Your presentation is incomplete. I'm sure Dr. Kosam will agree. Kosam will agree. You can't present this case without a pedigree chart. Both the parents have sickle cell trait. You have to draw a pedigree chart with the available information from the parents, and you have to find out, is there any relative who's getting repeated transfusions, any relative who has died early because of complications of sickle cell anemia, etc. Okay, that is something which is very, very important, right? And also, probably in your state, your sickle cell disease is so common, you may not give importance. But if it is somebody in South India, Chennai, I would have asked specifically from which subsect of the community they belong to. I'm sure Dr. Ajay Kosam would agree. I don't know, I don't know the data in your state. Some segments, for example, in Tamil Nadu, sickle cell disease is very, very rare. If at all we see sickle cell disease, it comes in Adivasis from some hill tribes, or sometimes in people of Saurashtra origin. There are many from Saurashtra who settled down in Tamil Nadu. It may be there in some Muslim communities. In pure Hindu communities, sickle cell disease in South India is extremely uncommon. So you must have found out more details regarding the social aspects of the family. Okay, that could give a clue to the presence of chronic hemolytic anemia like sickle or thalassemia. I'm sure Dr. Ajay would add something to it. Sir?
Yeah, definitely, because you have not mentioned about the specific religion or tribe they must be belonging to, because that is very common in our state.
Yes.
And how did you know that it is sickle trait? The father and mother both are sickle trait. How did you come to know that?
Sir, mother herself told that they are sickle cell. They have sickle cell small disease like that. They told, sir.
So did you screen the electrophoresis report or HPLC report?
Sir, there was no documentation available, sir, as per history only, sir, these things.
In fact,
So you
if the parents know that they have sickle cell trait, they would definitely know whether this child has got or not. I wouldn't believe that they don't know anything about it. Am I right, sir?
Yeah, definitely, because both of them know they have small sickle.
Yeah,
They
they
are
will know.
telling.
They will know whether
Yeah.
the child has got or the other sibling has got or not. I don't think they'll be so ignorant. Okay, go ahead. Go ahead. Go ahead.
What is the
Yeah.
electrophoretic pattern of sickle trait?
Sir, autosomal recessive, sir.
Electrophoretic pattern.
Electrophoretic pattern.
Hmm.
HB.
Suppose you're screening the. Yeah.
HBS.
Hello.
Sir,
Yeah.
HBS will be increased, sir. It can be up to from 30 to more than up to 90%, sir. HbA will be decreased and HbF will be somewhat increased and HbA2 will be normal, sir.
No, you should be very, very clear about sickle trait, electrophoretic pattern of sickle trait.
In sickle cell trait, HbA will be more, sir, than S.
Okay. A will be more than
Than S in sickle cell trait, sir.
Any other thing?
In alpha thalassemia also A will be more, sir.
No. In sickle trait, I'm asking. A will be more than S and
A2 will be normal, sir. F will be increased.
A2 will be normal. Okay. Yeah. Continue. Yeah.
In which condition A2 will give a diagnosis?
Sir, for thalassemia, it may be helpful.
Thalassemia trait more often. Right. Okay, go ahead. Sum up.
My patient named XY, 11-year-old Hindu male child, resident of Risali, Bhilai, immunized as per national immunization schedule, second order born out of non-consanguineous marriage, came with the chief complaints of fever since 6 days and yellowish discoloration of skin and sclera since 4 days, along with abdominal pain. He also had severe pain in both upper limbs and left leg since 3 days. He had a history of blood transfusion 6 years ago. In family, both mother and father are sickle cell traits. Apart from this, child is having normal birth and developmental history. From history, child likely to have a sickle cell disease with vaso-occlusive crisis, or it can be thalassemia intermediate, or it can be hereditary spherocytosis, or it can be any infection, or it can be leukemia.
1 minute. Now you put 5 diagnoses. Let me take it from the bottom. Why did you put leukemia as a possibility in this child?
Sir, it is the least possible thing, sir. By thinking
No, but
hemolysis.
why did you put it at all? I wouldn't put leukemia as at all as a possibility in this child. That's why I'm asking you this question.
Sir, thinking
I also
What
said
made you think of
but
leukemia?
leukemia, no features are resembling leukemia in this patient. Yeah. Most
What made
unlikely.
you think of leukemia in this child? See, 2 things. From the history, you are dealing probably with a hemolytic jaundice because the urine is not yellow, right? Scleral jaundice is there. And of course, you did not mention whether the child was becoming pale or anemic, which parents can find out, or increased fatigability due to severe anemia. This is likely to be a hemolytic anemia. Hemolytic anemia is extremely unusual in leukemia, right? It's not. But rarely hemolytic anemia may occur as part of lymphomas. Stage 4 lymphomas can have autoimmune hemolytic anemia, but as such, leukemias and lymphomas do not have hemolytic anemia as a presentation, right? And you have not obtained any history of lymphadenopathy or organomegaly. So leukemia is not a diagnosis I would have put in the DD. The second DD from bottom up, infection. What infections do you think can cause a clinical picture like this?
Sir, it can be leptospirosis, sir. It can be malaria.
Leptospirosis. Wait. Leptospirosis. What are the usual presentations of pediatric leptospirosis?
Sir, the usual presentation may be with jaundice, sir. Jaundice, fever.
Does it
fever
cause
bottle.
hemolytic jaundice or hepatocellular jaundice?
Sir, it causes hepatocellular jaundice, sir.
Then why did you mention leptospirosis as a diagnosis? Again, I wouldn't have thought of leptospirosis, though you are saying muscle pain is there. You know, the so-called leptospirosis can present with fever, suffused eyes, severe
Conjunctival suffused.
myositis, and hepatocellular jaundice and hepatorenal syndrome. You can have glomerulonephritis or acute renal failure, right? I don't think I will think of leptospirosis at all. What other infections would you have thought of?
Sir, it can be viral
Same
hepatitis.
story.
Viral hepatitis, sir. It can be.
Viral hepatitis. Viral hepatitis. Okay. Does viral hepatitis present with hemolytic jaundice?
No, sir. Yes.
Which viral hepatitis can present with hemolytic jaundice?
Hepatitis B, C, sir.
Rarely hepatitis B. In fact, hemolytic jaundice can be a manifestation of non-hepatotropic viral infections. Can you give a few examples?
Sir, dengue.
EBV, CMV infections can present with hemolytic jaundice, not hepatitis A. Rarely hepatitis B can present like an autoimmune disease with hemolytic jaundice. Hepatitis A does not present with hemolytic jaundice like this. Okay. Any other infection?
Sir, malaria can present.
Malaria. Which
fever
type of
malaria.
malaria can present exactly like this? Which type? Can anybody put in the chat box? Which type of malaria will present like this? With a hemolytic jaundice, severe anemia? Falciparum, obviously. Hello? 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 Am
Yes,
I
sir, you are
audible?
audible. Yeah, you
Yeah.
are audible.
Falciparum malaria can exactly present like this. That is what I would have thought of. If at all I had thought of infection, I would have thought of a falciparum malaria. Falciparum malaria. The only other infection I might have thought of is probably EB viral infection, which can present with hemolytic jaundice. Right? Because rarely in literature, one infection which closely resembles leptospirosis, which can present with the hepatorenal syndrome. Can anybody put in the chat box? There is one viral infection which can resemble leptospirosis, which is not there in India as much as in China, in Russia. Can somebody put in the chat box? The hantavirus infection. Hantavirus infection resembles leptospirosis and can present with the hepatorenal syndrome with jaundice like this and severe anemia. And renal failure, but that's not common. Okay. Other than this, I don't think I would have thought of infections because Kala-Azar in your state may be more common with limb pains, severe anemia, etc. They usually have significant organomegaly or leg ulcers, something like that. So I wouldn't have thought of infections also in this child. Whatever febrile illness may be an incidental viral infection. Okay, incidental viral infection. Do you think, why not this be dengue?
Sir, it can be dengue. Dengue, mostly the dengue course will be 5 to 7 days, sir. After that, the fever will subside, sir.
The only thing is dengue does not cause this sort of autoimmune hemolytic anemia. If at all it causes liver involvement, it can cause cholestatic jaundice due to HLH. Okay, not this sort of presentation. And child would be very sick and would have been in shock by now. That is not happening. Right? Okay. The next diagnosis you have put is spherocytosis. What are the points for and against?
Sir, hereditary spherocytosis has a wide variable presentation, sir. It can present at any age with the jaundice and hemolysis, sir.
So that may, See, anything can present at any age with any manifestation, but what is for and against spherocytosis? What is against spherocytosis?
Against spherocytosis, it is a dominant disorder, sir, autosomal dominant disorder, sir. If at all hereditary spherocytosis was for this child, there might be family history of gallstones and a splenectomy, or any positive history might be suggestive, sir. There is no positive history, sir.
See, the biggest point against spherocytosis is absence of organomegaly. A 11-year-old child with hereditary spherocytosis will have a near massive splenomegaly with jaundice. And any spherocytosis which is severe enough to cause a requirement for a transfusion will always have persistent jaundice. I don't think this jaundice would have appeared only 4 days ago if it is spherocytosis. Jaundice would have been persistent, and neonatal jaundice itself would have occurred in such a child. Right? The other points you mentioned are relevant. Okay? What about thalassemia intermedia?
In thalassemia intermediate, presentation will be in late age, so somewhat late age, but this age is unusual, sir, to be present.
See, two things. Again, thalassemia intermedia presenting at 5 years without organomegaly, requiring only one transfusion, and 6 years child has been well. And now coming with hemolytic jaundice acutely following a febrile illness, very, very unlikely. Unlikely. Tell me one other disease other that you have not mentioned, but I'll give a clue. Suppose this is a girl, 11-year-old, same story like this, severe anemia, severe jaundice, one history of transfusion in the past, acute febrile illness, and the parents say the left side of the abdomen is slightly distended for the last 1 month. What diagnosis, girl child, what diagnosis would you have considered?
Sir, it can be
Autoimmune hemolytic anemia or SLE. That is one diagnosis I would have considered, particularly if it had been a female. Even in a male, I would have considered that diagnosis, autoimmune hemolytic anemia. The only point from the history which is against autoimmune hemolytic anemia is the absence of an organomegaly from the history, So that can well explain the need for a transfusion 5 years back, and one more episode coming now. Okay, now last. There is one more diagnosis I would have considered in this child. Forget the sickle. So suppose there is no history of sickle cell trait coming. Same story. The child has fever, 11-year-old, goes to a primary doctor who gives anti-malarial medicines, and the same story of jaundice and severe anemia occurs. What's your diagnosis?
G6PD deficiency.
G6PD. Okay, that is one other G6PD or hexokinase deficiency. I would have definitely considered as a possibility. Of course, I would have elicited dark colored urine, ruling out the possibility of black water fever following anti-malarial drugs. Right? So these are all the diagnoses I would have considered. But then topmost you have put sickle cell anemia, sickle cell disease with veno-occlusive
Vaso-occlusive crisis.
Yeah. Okay. Vaso-occlusive crisis. Yes. Because of the pain. Here again, you should have got more history into whether there was any swelling of the digits, any dactylitis like presentation, okay, bone pain, etc. You should have elicited. Dr. Ajay Kosam, you want to question some more on history before we go to the physical findings? Sir?
Yeah. Basically, you have put a diagnosis of sickle cell disease with vaso-occlusive crisis, but you have not specified the crisis. Vaso-occlusive crisis is a broad terminology that includes number of conditions. So you should be specifying which vaso-occlusive crisis the patient is undergoing and what is the most likely VOC the patient is having.
Sir, Mostly it seems to be hemolytic crisis, if at all it is there.
A hemolytic crisis is not a vaso-occlusive crisis. Vaso-occlusive. What are the various types of vaso-occlusive crisis? Name them.
Sir, it can be sequestration crisis, sir. It can be aplastic crisis, sir. It can be,
These are not. This is not a vaso-occlusive crisis.
sir, it can be acute chest syndrome, sir. It can be acute stroke. It can be
Yeah, ACS, acute stroke. So
acute stroke,
is this patient
papillary,
stroke or
sir.
acute stroke? ACS है इसको? No, no.
No, sir. Acute chest syndrome.
What VOC is having? What VOC is having? He's not having stroke. He's not having ACS. Which VOC?
Sir, he's having hemolytic crisis, sir.
Hemolytic
bone
crisis
crisis.
is not a vaso-occlusive. Okay, this patient
Bone
is
crisis,
having
sir.
a
He's having
painful bone crisis. Okay. Any other crisis you must be suspecting in this patient apart from painful bony crisis, bone crisis?
can suspect sequestration crisis, sir, as patient is telling abdomen pain.
No. Sequestration crisis will not only pair with abdominal pain. Abdominal pain with jaundice is also there. You should be thinking of hepatic crisis. Abdominal pain is having, no? So when you are talking about diagnosis, you should be very specific which VOC the child is having. Most likely from the history and examination. Okay, yeah. Next.
In this child, it is probably, I mean, if you had got the history that the child has become more pale with increasing jaundice, then perhaps you can even think of some, I don't know, sir, you have a lot of experience, sickle, I have very little experience. I would think more of, in the absence of abdominal distension, I wouldn't think of sequestration crisis. I would have thought of only an aplastic crisis or a hemolytic crisis rather than a vaso-occlusive crisis. I don't know. You know better, sir. Okay. Right. You proceed for the physical findings, Dr. Rajkumar.
General examination was done. Patient is sitting comfortably on bed, conscious, alert, and oriented to time, place, and person, and having normal body movements. He's of thin build and undernourished. Glasgow Coma scores, GCS score showing 15 out of 15 on head-to-toe examination.
Before
Head
I
was
forget,
normal and
Rajkumar, in pediatrics, is this boy well looking or ill looking? You have a photograph or pictures of
at
this
the
boy?
time of the time of examination, he was well looking. Sir.
You say that. How can he look
At the time-
well with so much of problems? At least I would definitely. You have pictures of the boy?
Sir.
If you have, show me.
Because he is having severe pain in the limbs, so how he could be looking well?
Yeah.
This is
Okay.
he's
He
looking
doesn't. Okay. In this picture, he doesn't look too ill. Okay. He doesn't look too ill, but he looks thin built, and I don't know. I can't appreciate jaundice from the photograph. Okay. Right. Go ahead. Always you should mention first whether he's ill looking, acutely ill looking, chronically ill looking, right? Before you start talking about the rest of the parameters. Yeah.
Head was normal and hair was normal in texture, brownish in color and lusterless. Face was having maxillary hypertrophy seen in overface, and eyebrows were normal with symmetric movement. Eyes were normal.
How can you say eyes are normal when he has got jaundice?
Sure. In appearance, eyes were normal with no visible ptosis or nystagmus or squint. There was no KF ring. Icteris was seen in bulbar conjunctiva.
Deeply icteric, mildly icteric.
Sure, it was not mildly icteric, we can say, sir. Mild to moderate.
Yeah, you must always remember, any hemolytic jaundice, the icterus is less likely to be severe than a jaundice with this hepatocellular or cholestatic. Okay, right.
Mouth was normal, oral cavity, tongue, lips were normal, while oral mucosa was pale. Ear, nose, and throat were normal. There was severe pallor and icterus was mild to moderate. And there was no lymphadenopathy, no edema. Nails were normal in appearance with no clubbing. Skin doesn't show any neurocutaneous markers. BCG scar was present. No peripheral nerve thickening. Chest and abdomen are normal. No signs of vitamin deficiency. No signs of any cranial nerve involvement are seen.
Why you mentioned peripheral nerve thickening?
Sir, for normal examination, sir, related.
How often have you seen peripheral nerve thickening? That too in this child who's got jaundice, I don't think it is significant. Yeah. Go ahead.
Vitals, temperature was normal in.
Just interrupting you, you have not
Those
mentioned anything
taken
about
in
bones
right
and
exam.
joints. Bone, joint, and skin. You have mentioned that the patient is
So
having
skin
pain
was
in the limbs. Bone, joint, and skin.
the bone joint examination was normal, sir, unless he was having some pain while movement, sir.
No, the history is suggestive of pain in the limbs and around the joint. That is what you mentioned, no?
No, sir.
So you should have done a detailed examination of the bones and the joint. How do you examine the bone and the joint?
Based on P-Girls scoring, sir, pediatric gait, P-Girls.
You did that?
Sir, I have done, sir. It was normal, sir, but I haven't mentioned in this, sir.
Okay, so there was no bony tenderness, there was no joint involvement, there was no signs of inflammation of the bones or the joints or the skin.
Sir, mostly the pain was muscle pain, sir. It was more severe around the joint. There might be some sort of effusion, sir. Mild
Muscle
effusion
pain
might
around
be
the
there.
joint. Be very specific. Muscle pain around the joint. How it is possible?
Sir, in upper limbs, it was
Around
muscle pain. In upper limbs, it was muscle pain, sir. In only in a right limb specifically, there might be some mild effusion might have been there, sir.
so there was no restriction of the movement of the joint.
There was no complete restriction, sir. On passive movement, he was okay, sir. If at all, there was mild, there were painful movements, sir, but there was no complete restrictions.
Painful movement of what? Joint.
Joint.
Which joint?
Right upper limb joints, right wrist joints.
So it was arthritis or arthralgia? Or
Sir,
it was periarticular involvement?
Sir, it seemed to be arthralgia, sir. It was not arthritis.
How did you come to your conclusion? It was arthralgia, not arthritis.
Sir, in arthritis, there will be joint movement restriction, sir. In arthralgia, joint is mobile, sir.
So he was having subjective pain, but no objective pain on examination or tenderness.
There was tenderness while movement, but not that much significant, sir, which later on improved, sir.
So then you can't call it as arthralgia then. Joint swelling was there.
Sir, there was no significant joint swelling, sir. There was mild, sir. It can be, sir.
So mild swelling was there, no? So swelling itself suggestive of arthritis. If you have swelling, it means there is arthritis. No? If there was no swelling, then you would have said it was not arthritis. So there must be some involvement of the joints. Okay, now continue. Next slide.
Go ahead. Go ahead.
Temperature was normal. Pulse rate was 102 per minute, regular in rhythm, normal in volume and character, no radiofemoral delay, and all peripheral pulses are felt equally on both sides. Respiratory rate was 21 per minute, regular in rhythm, thoracoabdominal type. No use of accessory muscles of respiration. Blood pressure was 98/62 mm. It's in the right upper limb in supine position, using the appropriate cuff size. SpO2 was normal in room air with RBS, and RBS was normal.
Go ahead.
Trigonometry. Weight was 27.3, while expected weight was 34 kg. It was in between 25th and 50th percentile. Height was 130 centimeter and expected was 142 centimeter. And it was between 3rd and 5th percentile. BMI was 16.2, while the expected was 17. It was between 5th and 10th percentile. Head circumference was 51.5 centimeter. Systemic examination per abdomen.
Before you continue, it's very important to note that his growth has been essentially been normal, indicating whatever disorder that he has, it doesn't seem to have affected his growth. Some acute decompensation only had occurred. That's one conclusion I would draw from your anthropometry. Second is your general examination is incomplete without mentioning of the SMR of the boy. 11-year-old, definitely you should mention that is a male child. There should not be any difficulty in you examining the SMR and assessing. You should assess the SMR. For chronic diseases, you have to find out whether there is any endocrine involvement. That can be assessed only by doing an SMR. Okay, make it a habit to include that in the adolescent examination, male or female. Okay, with due precautions and due respects to the privacy of the child. Go ahead.
Systemic examination, per abdomen examination on inspection, shape is normal. There are no visible scars, sinuses, or dilated veins. Umbilicus was inverted. All quadrants were moving equally with respiration. No visible peristalsis or pulsations. Flanks were free. Hernial orifices were free. External genitalia are normal. On palpation, abdomen was not warm or tender. No gouging or rigidity are seen. Liver was palpable, 2 cm below the right costal margin, soft in consistency with round margins, soft surfaced with no tenderness. Spleen was palpable and was in 4 cm with soft consistency with mild tenderness. No other masses were palpable. On percussion, liver span was 12 cm. No shifting dullness or fluid thriller seen. On auscultation, bowl sounds were heard and there was no bruit or venous sound.
You have the picture of his abdomen?
Sir, no sir. It is in another laptop.
Now with the spleen of 4 cm below left costal margin with the liver span of 12 cm, you mentioned that there is no distension at all. I don't agree. He will definitely have upper abdominal distension. He will definitely have displacement of the umbilicus down, and he will definitely have stretching of the umbilicus in the side. Even from the history, their parents will agree that there had been abdominal distension. That's what I said. There is definitely organomegaly, and I am sure it would manifest as abdominal distension. Okay? I don't think your statement that abdomen is not distended is correct. Please don't mistake me. I'm just cautioning you. The exams, sometimes strict examiners might question you on everything you say. Right? Please go ahead.
Sir, we can tell mild distension, sir, but it was not significant.
No. Distension is distension. Whether it is mild, moderate, or severe, that is very subjective. But I don't think a child who's got a liver span of 12 cm and a splenomegaly of 4 cm can have a normal looking abdomen by inspection. Right? Fine.
You mentioned that spleen is tender on palpation, no?
No, sir.
And soft consistency. I don't agree with your consistency.
Sir, it can.
Soft consistency of.
It was in between soft to firm in consistency, sir. Strictly speaking, it was in between.
No.
Because usually in a chronic hepatic anemia, spleen is chronically enlarged, it is firm. Soft spleen in a chronic hepatic anemia is unlikely. Tender. What is the cause of tenderness? Spleen tenderness. Cause of spleen tenderness?
It can be splenic sequestration, sir.
What sir says is very,
Any other
very
thing?
relevant. What Dr. Kosam says is very, very relevant. Liver will be soft only when there is fatty liver. All other livers, including cardiac failure liver, due to congestive hepatomegaly, will always be firm. On a similar note, soft spleen you will get only in typhoid, when there is minimal hypertrophy of the reticuloendothelial system. In a disease like, thalassemia or sickle cell anemia, the spleen, unless proven otherwise, has to be firm because it is a congestive splenomegaly. And tenderness in spleen is a very, very unusual finding. It can occur when there is a splenic infarction or perisplenitis. It doesn't occur commonly. Doesn't occur commonly. You have to check it out, right? Okay. Please go ahead.
In sickle cell
CNS
anemia,
examination.
even splenic abscess can cause tenderness. Yeah.
Yes,
Splenic
yes,
abscess is common in sickle cell.
yes. Infarct, abscess, perisplenitis, right? Or trauma to the spleen. Trauma to the spleen. These are the few situations in which the spleen is tender. Agreed, sir.
CNS examination, patient was conscious and oriented. No focal neurological deficits were there. CVS examination was normal with both heart sounds were heard and no added sounds or murmurs.
I don't think you are likely to have normal CVS examination. I'm sure this boy who's got a chronic problem with so much of liver spleen failure will have some systolic murmur and venous hum. Very, very unlikely that there are no added sounds or murmurs, right? Fine. The commonest findings
Because
you
patient
get
is
in
also
the commonest finding you get in chronic anemia are an ejection systolic murmur in the aortic area and left sternal border, and a prominent venous hum and cardiomegaly and a bounding pulse, right? In fact, you had mentioned blood pressure also some 92/68. I don't think you will get such a narrow pulse pressure in such a child who's got severe anemia. There will be wide pulse pressure also. Bounding pulses also may be there, right? Go ahead.
Respiratory system was normal with chest movements equal bilaterally. Bilateral air entry was equal. Normal vesicular breath sounds in all areas were heard. No added sounds or no distress was seen.
Go ahead.
Patient named XYZ, 11-year-old Hindu male child, resident of Risali Bhilai, immunized as per national immunization schedule. Second order born out of non-consanguineous marriage, came with the chief complaints of fevers in 6 days and yellowish discoloration of skin and sclera, along with abdomen pain since 4 days. He also developed pain both upper limbs and left leg since 3 days. In family, both mother and father are known to be sickle cell traits, and he had a history of blood transfusion 6 years ago, else having normal birth and developmental history. On examination, child is underweight, undernourished, vitals are stable. He had mild tenderness in right hypochondrium region and hepatosplenomegaly with pallor and icterus. Hemolytic phases is seen and other system examinations were normal.
Can you show his face once more? What do you mean by hemolytic phases?
Sir, maxillary hypertrophy is seen. Sir.
Prominent maxilla, along with jaundice. Of course, you are all probably more used to picking out thalassemic phases or hemolytic phases. Yeah, he looks fairly nourished, and his maxilla, yes, agreed. It looks a bit more prominent than usual. Right.
Apart from maxillary hypertrophy, nothing is suggested.
Okay, okay, go ahead. Go back. Go back. Yeah. Yeah.
My diagnosis, 11-year-old male child with complaint of fever, jaundice and limb pain with history of blood transfusion in past, with family history of sickle cell trait in both the parents, with examination revealing pallor, icterus and hepatosplenomegaly is most likely a case of sickle cell disease with vaso-occlusive crisis.
Okay, my question to you is, you have made a diagnosis sickle cell disease, agreed. Possible vaso-occlusive crisis, maybe. But what is the reason for the fever?
Sir, fever may be due to infections or any infection.
Which infection?
Sir, capsulated organism.
Where is the infection? What is the infection?
Sir,
Where is the infection? What is the infection?
Sir, it can, if at all it is in joint, it can be Salmonella typhus.
Salmonella. Salmonella.
Or
Oh God. What is the relationship between joint disease and Salmonella?
osteomyelitis, which occurs in sickle cell, can be due to Salmonella typhus, or it can be.
You think this fellow has got osteomyelitis?
No, sir. No, sir.
Yeah, that is one. One is yeah, agreed. Salmonella osteomyelitis is more common in sickle. 1, 2. Anything else? What is the
Anything which is-
relationship between arthritis and salmonella?
Sure.
Rarely, non-typhoidal salmonellosis can present with osteomyelitis. Non-typhoidal salmonellosis can also cause reactive arthritis. Rarely, even enteric fever can present with reactive arthritis. They are all very, very uncommon. Uncommon, not common. Okay? And you must remember a lot of gastrointestinal infections such as Campylobacter, Yersinia can present with reactive arthritis. Reactive arthritis. Shigella is notorious for causing reactive arthritis. Hepatitis B can cause reactive arthritis, right? And you can have, in fact, chikungunya is one disease I would have considered in this child who has got so much of limb pain with acute fever. So there is no rash, need not be there. Dengue, of course, one should have considered in this child, right? Coxsackie viral infections are notorious in causing severe myositis and painful limbs, right? One other finding which you should have mentioned when you say vaso-occlusive crisis is your attempt to palpate all the peripheral pulses starting from temporal artery down to the posterior tibial, right? Okay. So you think this is sickle cell disease? Sir, Dr. Kosam sir, you must be an expert in sickle. I think you should take forward the discussion from here. Please go ahead, sir. Sir? Hello?
He's not here, sir. I think so.
Yeah, go ahead. Go ahead. Please take the discussion forward, sir. You must have seen hundreds of cases like this. Please go ahead.
He's not here, sir.
What happened? His connection is lost?
Okay. Might be, sir. I'm talking to him.
Okay. Sir, what are your comments on a diagnosis of vaso-occlusive crisis in this child, sir? You must have seen lots of cases. How do they usually present? Sir? Hello?
Sir, he's not here, sir.
Okay.
I'm just trying to correct him, sir.
For completion's sake, sir, please comment on the manifestations and the presentation of vaso-occlusive crisis you have come across commonly, sir.
In inclusive crisis, the most dreaded is the stroke. The second most common. Hello.
Yes, sir. Please go ahead.
The second most common would be acute chest syndrome, that is life-threatening.
Yes, sir.
Then, apart from that, the other vaso-occlusive crisis which come across that is uncommon is priapism. That is more common in the older children. That can cause impotence also. And apart from that, you can have intrahepatic sickling causing right upper quadrant syndrome, that is called as intrahepatic sickling, RUQ syndrome, hepatic crisis. So these are vaso-occlusive crisis which we come across. Others are the sequestration crisis. I think he's having abdominal pain and limb pain. So limb pain means he's having a painful bone crisis causing bone ischemia and bone infarct. And abdominal pain is having, so there could be a part of mesenteric sickling causing abdominal pain. So these are the vaso-occlusive crisis, most likely.
Okay. He could be having even occlusion of mesenteric artery. You never know, because causing severe pain. But of course, the pain is not very significant. Very significant. His hemoglobin is coming down. Okay, right. Sir,
and since he's not having any history suggestive of hepatic involvement, so intrahepatic sickling or hepatic sequestration is unlikely, because usually they're associated with conjugated hyperbilirubinemia. So they're likely. Neither it is cholecystitis or cholelithiasis.
Yeah.
Likely.
Most probably an acute viral infection must have precipitated a vaso-occlusive crisis. Which worsened his anemia and also decreasing the hemoglobin, and he's got hemolysis because of the sickle cell disease. Now, How
Yes,
is it that this boy who has got sickle cell disease, I know you must have a lot of experience. At 11 years, he's well grown. He has required only one transfusion. How come he has gone on so long without much of problem, sir? Is it common or that's how
Sir,
you?
usually we see very highly varied presentations of sickle cell anemia in our state.
Yes,
Some
sir.
of them they require transfusion every month. Usually they are sickle thalassemia, sickle with beta zero thalassemia they are. So
Yes,
they
sir.
require transfusion every month. Some
Mm.
of them they are having associated sickle cell anemia with alpha thalassemia trait. If they have sickle with alpha thalassemia trait, their severity becomes lesser. And sometimes they have a high fetal hemoglobin level, so they are relatively stable and require less transfusion. So we have seen many cases of homozygous sickle, they present quite late, and some of them they present even in the adulthood during pregnancy. That might be related to their HbF level or their other associated hemoglobinopathies, which might have decreased the sickle severity, like alpha thalassemia.
Okay. Okay. This child, do you think you would have managed only with a simple transfusion if the hemoglobin is around 4 or 5, or you would have gone ahead with an exchange transfusion, sir?
Sir, in this patient, because there is a no life-threatening crisis, so simple transfusion will suffice. But usually exchange transfusion is only required if it is a life-threatening crisis, like is having a stroke or is having an acute chest syndrome, not responding to simple transfusion. Then only we may plan exchange transfusion. But otherwise, for a simple vaso-occlusive crisis with a drop of hemoglobin of more than 2, simple transfusion, I think, will suffice for this particular patient. If the hemoglobin is
One question I wanted to ask you. See, usually it is said that in sickle cell disease, beyond 5 years, spleen is rarely palpable because of repeated auto-infarction. This boy is 11 years old and his spleen is palpable. How often you see like this, sir?
No, sir, we see most of the patient of sickle, they have palpable spleen.
Even beyond 5 years?
Yeah. We read in the book that auto-infarction, autosplenectomy happens, but we are seeing most of the patient with sickle, they have splenomegaly. They don't have a non-palpable spleen.
Yeah, in fact, I can only quote what I have read from books. Books say that if you have a significant spleen above 5 years, and if you have hemolytic anemia, you need not think of sickle because of auto-infarction, destroying the spleen below 5 years. That's a very interesting point you have come up. And the next question I wanted to ask you, sir, you are an expert. Suppose you had seen this child at 3 years sickle. Do you give penicillin prophylaxis for these children or you don't give?
So it is mentioned in the books, but I think in the routine practice, none of us are giving penicillin prophylaxis to the patient. We are focusing on the immunization rather than giving penicillin prophylaxis, because it is practically not possible to give daily penicillin for 5 years or beyond. So practically it will not be feasible. So most of us, we are not giving penicillin prophylaxis.
Do you see a lot of pneumococcal disease in such children below 5 years?
Yeah. We see a lot of patients with sickle cell with septic shock, pneumonias. So this is very, very common.
Very common. That's very interesting. And this child, of course, after tackling the crisis, what other management options you have, sir, for this child, 11-year-old?
And in this particular patient, basically most of us, we are giving hydroxyurea and immunization. That is what we are focusing on, and preventive measures. Because otherwise he is doing well, but as he grows up, he will be having chronic complications related to the bone or related to the skin or related to the heart. And as the age advances, the child is exposed to environment more and more. So he will be having crisis. So hydroxyurea we must start in view of.
It's a pretty safe drug, isn't it? It's a pretty safe drug.
Yeah. Most of the patients, in fact, all of the patients, they receive hydroxyurea for prolonged periods of time. It is quite safe. None of us have seen leukopenias or thrombocytopenias or complications happening with hydroxyurea in our practice.
Do you monitor them with blood counts once in 3 or 6 months, or you don't?
And we do it every 6 to 8 weeks.
And how about folic acid? You give 5 milligram supplements?
Yeah, we give it on a daily basis. Yeah, definitely.
Okay, sir. Okay. Is there any routine screening in your state in the newborn period for sickle or thalassemia? You have some program to detect because the
No, sir, there is no routine screening. No routine medical screening is there.
Hmm.
No routine
Hmm.
screening. Yeah.
Okay, sir. Okay. That's, I think, that's a very useful data I learned because I don't see sickle cell like you see in hundreds and a lot of cases you must be seeing. Your experience must be really fantastic, right? Any other input from you, sir, to the student community? You want to give a message on this case, sir?
But I think that whenever we are presenting a common case of hemolytic anemia, we should present the case in entirety. Entirety in the sense that in this particular case, the abdominal complaints, the joint complaints, they should have been described in a much detailed way because it is such a common case and a lot of
Yeah.
complications do happen in sickle cell anemia. So
Yes.
all the abdominal complications, all the bone complications, all the joint complications, they should have
Mm.
been covered in totality in the history itself. That would
Correct.
have given us more clue regarding what is the cause of abdominal pain, whether at the
Absolutely.
joint is because of osteomyelitis or arthritis or sickle bone crisis. That was not clear. So I think
Correct.
that was one thing I wanted to share. Yeah.
Excellent. Very useful input, sir. I learned a lot from you. Thank you very much. Over to Dr. Kishore and Dr. Motwani for their comments before we wind up. Excellent presentation by Rajkumar. Unfortunately, he lost his connection. Well done, Dr. Rajkumar. All the best to you. Thank you very much.
Thank you,
Sir.
sir. Thank you, Bala sir. Thank you, Kosam sir.
Please,
Sir.
the slides and over to Dr. Kishore. Can you close the
Sir.
slides, please? Stop sharing the slides and before Dr. Kishore takes over. You can stop sharing the slides. Stop sharing. Yeah, yes, Dr. Kishore, over
Yes,
to you.
sir. Just I want to, sir, put one input, sir, that in case of sickle cell anemia, the sequestration occurs in toddlers only, sir. It is most common in toddlers, sequestration.
Okay, okay. Young age only.
Yeah, yes, sir.
Okay. Thank you. Thank you.
Sir, I would like to thank Dr. Rajkumar for his nice presentation and excellent discussion. And I'd like to thank our faculty, Dr. S Bala sir and Kosam sir, for their interesting.
Very valid points raised by him. I learned a lot. Thank you very much.
Yes, sir. For sparing your valuable time with us and sharing your knowledge and thought process with us, sir. Thank you. Thanks a lot, sir. Thank you all the viewers who are attending this session. And last but not the least, thank you, Mr. Yogesh Joshi ji, for providing us this digital platform for the presentation. Thank you all. Good night. Thank you, sir. Thank you all.
Thank you.